All right. Well, good official morning, everyone. Thank you so much for joining us. I think I'm going to go ahead and get started. We do have about 156 people joining us this morning, so I think it's a good number to get us started. Again, thank you so much for joining us this morning. Welcome, welcome, everyone. If you can just drop the agency that you're joining us with, but a big welcome to today's webinar topic, which is marijuana and the perinatal period, impacts of parental usage on development and lactation. Before I get started and introduce our wonderful speaker, I do want to give a brief background about our home visiting consortium. If you're joining us for the first time, just really briefly want to introduce the LA County Perinatal and Early Childhood Home Visitation Consortium. Brings together more than 60 home visiting programs, family and child health organizations, and community partners. Together, we strengthen LA County's home visiting systems through shared trainings, resources, research, data collection, improved referral, and advocacy for policies that recognize the vital role in home visiting services. If you are curious about learning more on the consortium, or if you want to join any of our 6 work groups, I did include a QR code which you can scan to find out more. And then some important information for this webinar. Just a reminder, this presentation is being recorded. All the recording and the materials will be sent in a follow-up email, and then we do also upload the recording and presentation on our consortium website as well, so you'll have access to that a few days after the webinar. And then just a few to-dos for us to know. If you do have any questions throughout the webinar, please use the Q&A box to engage with our speaker. And then if you have any other comments, please use the chat box and please continue to introduce yourself and your organizations. We love the diversity in the chat. So thank you so much again for joining us. And then at the end of the webinar, I do want to mention that we have a brief evaluation that you can fill out. Your feedback is extremely important to us. We read through every single response to see what trainings the consortium can put on next for our staff. So anything you have in terms of feedback, we would greatly appreciate. All right. Well, with all of that being said, we are extremely excited and grateful to be joined by Dr. Jane Singer this morning. Just a little bit about Dr. Singer. Dr. Singer is a clinical psychologist with over 40 years of experience in hospital, school, and community-based settings. At Boston Children's Hospital, she provides evaluation and treatments for families and children aged birth through childhood with medical, developmental, emotional, behavioral, and familial challenges, including trauma. She is an assistant professor of pediatric and psychiatry at the Harvard Medical School and an international facilitator of the Brazelton Touchpoints approach and the newborn behavioral observations NBO system. Dr. Singer, thank you so much for joining us this morning, and I will pass the mic to you to get us started.
Terrific. Thank you so much for that warm welcome and for the opportunity to be with you all today. I'm going to go ahead and share my screen to get us started and to thank all of you for the work that you do every day. One of the things that was missing in the introduction, not that Anna would have known this, but I am a former home visitor, so I am extremely appreciative and admiring of all of the important work that you all do. And I know that there's many other ancillary disciplines represented among the group today. So a warm, warm welcome to everyone. And please also do know that I'm not going to be speaking at you for an hour and a half. I know that this is a webinar meeting format, so we're not going to be able to get into breakouts or to come off mute, but I do very much encourage you to use the chat feature and the Q&A feature. There'll be various points where I'm going to pause what I'm talking about and invite you to reflect, invite your questions, invite your comments. There'll be other times where I'll invite you to use a Mentimeter so that we can have a visual representation of what some of your thoughts are. So please get ready to be engaged with me and with each other. I do not have any conflicts of interest to report. I will disclose, as Anna said, that I am a clinical psychologist. I'm an infant and early childhood clinical mentor, infant and early childhood mental health clinical mentor. And I work at the Brazelton Touchpoints Center. I'm a master trainer of the NBO and of the Touchpoints approach. So there are going to be a couple of different points during the course of this presentation where I will pull in some ideas and some materials that I have developed for some of those other trainings, and I'll make note of that in the relevant slides. I will disclose also that I was invited to deliver this presentation by the LA Best Babies Network, which is the oversight entity for the First Five LA and Department of Public Health funded home visiting programs. And also, all the research that I make mention of today, I will provide the citations for at the end of the presentation, and you'll also have that in a slide handout that you'll receive. So if you want to take a deeper dive into any of that research, you'll have some avenues that you can walk down and find out more for yourself. So let's get started. Um, I'm going to do a little bit of an introduction to our topic, which again was cannabis use during pregnancy and lactation. And I'll share a little bit with you of what some of the desired objectives are for our time together that really came from this invitation to be with you today. My understanding is that that invitation was in response to questions and wonderings that many of you have had in the course of building your relationships and supporting the families who are in your care. Then we'll explore the landscape a little bit about what do we mean by cannabis? What do we mean by cannabis use? What do we mean by cannabis use during pregnancy? What do we mean by cannabis use during lactation, right? And then we will pivot around to, given what our curiosities are and our concerns might be, what are some ideas about engaging families, especially when we might have questions or concerns about cannabis use. And like I said before, I'll include some resources and some citations, and we'll end the time together, so really lifting up and highlighting the key takeaways. All right, so our mission, should we choose to accept it today, we're going to be learning about some of the developmental effects of cannabis use on the part of the pregnant person during pregnancy, as well as some of those effects during the perinatal postpartum lactation period. We're going to be thinking hard about the context in which we're having the conversation, right? Which is relatively recent changes in attitudes towards cannabis use that have happened since increased legalization and accessibility of cannabis, and what are some of the attitudinal changes that have come about among pregnant persons. We'll explore some realistic techniques that we can use to support and encourage parents to stop using cannabis. So I'm already cutting to the chase here in thinking about what some of the concerns might be and why we would want to support families in cessation of use. And what are some of the specific examples of language that we can use in our screening and our assessments um, that refer to exposure prenatally, exposure through breast milk, exposure through secondhand smoke. So to get us started, I know we have a lot of people here. So what I would really like to do is launch a poll to find out from you, inquire of you, how often does this topic of cannabis use come up for you in your home visits or in your contacts with family if you're not a home visitor? Is it pretty much every single time? Like, this is part of my conversation every time I do an intake and I'm starting my work with a family? Frequently, maybe at least once a month? C, it comes up, but it's not a regular part of your work. Or D, never. All right. So let me go ahead and launch the poll. So you should see on your screen a poll that you can interact with. All right. And as you all interact with it, I'm going to get a chance to get a sense from you of what the landscape is. All right. So far, more than half of you have participated in the poll, and most of you, almost half, are reporting that it's come up, but not a regular part of your visits. For some of you, a little more than 10% of you, it comes up every visit or every intake. For some of you, about 14% of you, never comes up. And then there's about a quarter of you where, like, yep, at least once a month, it's coming up in clinical or home visiting interactions. All right. So thank you for that. That already gives me a little bit of a sense of what your day-to-day lives are like in terms of having these conversations with families. So let's move on from there. So in the poll, whether you answered that this is something that is a very frequent part of your work with families or not, what's on your mind? What is on your mind about pregnant and birthing parents' use of cannabis? And to help us gather your thoughts and your ideas, I've put a QR code on the screen. If you're familiar with Mentimeter, you've probably done this before where you can take a device, take your phone, scan the QR code. It's going to bring you right to the Mentimeter, right? Um, if you're not familiar with that way of doing it, I'm actually putting the link in the chat. And if you don't want to or can't use the QR code, you can actually, right from the device that you're on right now, just click on the Mentimeter link that's in the chat. In either case, it's not going to kick you out of the webinar. It's going to open up a new page on your device, and it's going to ask you what's on your mind about pregnant and birthing parents' use of cannabis. All right, so I'm going to give everybody just a few more seconds to engage. And then I will pull up the word cloud that your input is going to create. And that'll give us a sense of what it is that you're wondering about. Why is it that you came to this particular webinar? All right. So I'm going to go ahead and stop sharing for a moment so that I can pull up our word cloud. Okay. All right. So if you have participated in a word cloud before, you know that the more often any one person enters a particular word, then the bigger that word is going to appear in the word cloud, the more central it's going to appear. So many, many of you have concerns about safety. Safety, health, is it harmful? What's the impact? Is it healthy? Is it dangerous? What are the effects? What are the short-term effects? What are the long-term effects? So even if safety was not your word, you can see in our word cloud, right, that there are many, many, many things on your mind about families and cannabis use before the baby's born, after the baby's born. A lot of you are listing your emotions. You're sad. You're worried, right? You're concerned. Some of you are listing your specific concerns about the health for the baby and the harmful effects. and the impacts over time. And some of you are wondering, are there positive aspects postnatally? Hmm. Is it really harmful? How does this affect the baby? How does it affect a parent's ability to care for the baby? Right? And still others of you have protective concerns. Does it result in a child protection filing? Child Protection Services, DCF, right? How legal or illegal is it, right? Even if the substance itself might be legal where you are. But what about its use during pregnancy and again during lactation or over time, exposure to the child through secondhand smoke? And some of you have said you wonder about how responsible or irresponsible is it to engage in cannabis use, right? And so we're already letting ourselves also be aware of our protective urges towards the baby and the children. And when we have protective urges, some of those judgments that we may feel or think towards and about parents. Oh, and we're already seeing in the chat from someone, I had no idea that patients engage in cannabis use. Okay, so we're going to learn a lot together today about how frequent this is and what are the potential risks involved, and then what are our responsibilities, right? Oh, I even see in our word cloud doctor permission, and we're going to get into that a little bit too, about why. Why might someone be choosing to use cannabis during pregnancy or during lactation, and with what kind of conversations with their healthcare team or healthcare system. All right, let me just do another scan, make sure that there's not anything. Oh, yes, and somebody already also knows about hyperemesis, and we're going to get to that also about some of the risks of cannabis use. All right, so let me stop sharing our word cloud for now. And if you want me to send it to you all later, I can certainly do that. All right, let's go back to our slides. Thank you for the heart in the reactions. I assume that that's a thank you. All right. So we all have learned to read each other's body language through Zoom. All right, so let's start here. I promised a little bit of an introduction. What do we even mean by marijuana? So you've noticed that what I've been using is the word cannabis, right? There are different forms of cannabis. Typically, when we're talking about cannabis use, it's one of three different potential strains of cannabis. All cannabis does have within it THC, which is the psychoactive piece, right? That alters brain functioning in terms of perception of reality. That's what we mean by psychoactive. THC is the chemical in cannabis that actually binds with certain cannabinoid receptors in our brains, right? And then cannabis also has, yes, Evelyn, you're getting a copy of the PowerPoint. um, and then cannabis also includes CBD, which does not bind as strongly to those same receptors in the human brain, but CBD use does increase people's own neurochemistry to produce more of those endogenous cannabinoids, like our our own naturally producible neurochemicals that would mimic cannabis. How is it used? You probably all know this. You can smoke, there's vaping, ingesting edibles, topical solutions, oils, and even mucosal. What do we mean by that? We mean sprays, tinctures, oils under the tongue, and even suppositories. Here's a huge issue, even with the legalization, right? Is that cannabis itself is not regulated by the Food and Drug Administration, right? There are no regulations around the production and the labeling of products. So not only do our THC products four times more potent right now than they were in 1995, for example, that many products that are marketed and sold as CBD products actually do contain THC. So it is hard to be sure if someone is deciding about cannabis use. It's hard to completely ensure that they are having uh, uh, not having THC. I'm sorry. I want to look in the chat. I saw another chat. Okay. All right. All right. Please, by any means, if you have questions as I go through this, feel free to put them in the chat or the Q&A, and I'll do my best to monitor some of those as we go along. The main idea for today is that we want to understand is that because of legalization, there has been a wider spread of social acceptability and acceptability, right? So acceptability and California, yeah. Now there's no FDA, there's no federal regulations around production, right? So one product might have um, a much higher load of THC than another product, for example. So along with the perceived social acceptability, there's also been greater accessibility, right? It's very easy for people to find and purchase and have cannabis products. So what the landscape shows is that since that has happened and is happening, there have been greater and greater perceptions that it's safe to use cannabis during pregnancy and lactation. Okay, so here's some of the statistics. Um, it's estimated that among 19 to 22-year-olds across the country, around 43% use cannabis on some basis. May not be daily use, but the rates of daily use are rising. The highest proportion, what this means is that the highest proportion of people overall who are using cannabis are of reproductive age, right? Whether or not they're intending to get pregnant at that time. And usage of cannabis itself during pregnancy has increased tremendously over the last 20 years, 10 to 20 years. And the estimates are up to about 16 to 20%, 22% of pregnant and or lactating people are using cannabis. During pregnancy, and this may not come as a surprise to anyone, the highest frequency of reported use is during pregnancy in the first trimester. So of people who report cannabis use during gestation, during pregnancy, they're reporting use during the first trimester. All right, and we're going to come around to wondering together why that might be. And then as cannabis use tapers off during the course of pregnancy or gestation, Studies also suggest that returning to use or increasing use postpartum, 6 months, 12 months postpartum, is quite common. All right. So let's open this up for some conversation as much as we can in the chat. What are some reasons that you know of why your client, if you have clients who you know have been using cannabis during pregnancy or breastfeeding, what are some reasons that you know of why your client might be using cannabis? So I'm inviting you to interact with us and each other in the chat. Thank you. Anxiety. Okay. So we're having a lot of people put into the chat anxiety, stress, mental health, anxiety, pain management, nausea. Okay. Helping them relax, anxiety. Okay. So we're going to come back to this idea of hyperemesis. So for folks who may not know what that is, right? Um, you hyperemesis is you're losing too much bodily fluid through nausea and vomiting, right? And so there may be the perception that, oh, if cannabis use can help with nausea under other medical conditions or circumstances, maybe it would help with nausea, even hyperemesis in pregnancy. Nausea and appetite. Yes, people thinking, oh, it's safer than drinking. You might have somebody saying, well, I know alcohol is not safe during pregnancy, so cannabis use might be safer. Self-medicating. Yeah, so self-medicating for what? Right? Self-medicating for stress and anxiety. Appetite, increase, right? Morning sickness, insomnia, right? Morning sickness again, previous usage because of histories of trauma or histories of mental health. All right. So we have a sense of the increased prevalence. We also have a sense of why it is that um, birthing, pregnant or birthing or lactating persons might feel that they are wanting to use cannabis. But let's take a look at what the data shows us about whether or not it is safe. Okay? So, during pregnancy, no big surprise, most people who are self-reporting cannabis use during the pregnancy report that they're self-treating nausea and vomiting. And I'm saying self-treating, meaning a medical professional is not advising it. They're self-treating nausea and vomiting. However, one very large-scale study, right, 9,250 pregnant people, found that higher levels of THC in people's metabolites, higher levels were associated with greater odds of moderate to severe nausea, and that those symptoms of moderate to severe nausea actually resolve if the person ceases cannabis use. So there's actually not good data to suggest that it helps with emesis. And in fact, there is a condition, there's a syndrome, cannabis hyperemesis syndrome, meaning that the actual cannabis use itself can bring about hyperemesis, excessive nausea, vomiting, right? That's dangerous for the birthing person and the developing fetus. That syndrome is associated with higher potency use or more regular cannabis use. And then the other reported reasons, right? Anxiety, depression, stress. Okay. So I'm just going to let this kind of sink in a little bit, right? That actually there are no medical indications for cannabis use during pregnancy. Sorry, let me just move this. And let's think about why. All right. So the developing brain prenatally, the developing brain peri and postnatally, right? Both periods of an intensively rapid brain development. So in a developing fetus's brain, there are actually cannabinoid receptors present in the fetus as early as 5 weeks gestation. And THC is fat soluble, it's lipid soluble, right? And it can transfer across the placenta. Not at the same concentration as in the birthing person's metabolism at about 10%, but it still does cross over, right? And does then also start to um, connect with, right, those cannabinoid receptors in the fetal brain. What the research indicates, right, is that cannabis use during pregnancy is associated with lower birth weight, small for gestational age, right? Meaning um, it's like lower birth rate, but meaning that all through the pregnancy, the developing fetus is smaller than uh, what one would protect, would what one would expect, right, for that gestational age. There's higher rates of NICU admissions and higher rates of perinatal mortality. There's also studies that show that cannabis use affects fertility, even in trying to conceive, right? So even before pregnancy. It is very difficult to study this rigorously, right? Because cannabis exposure might be associated with exposure to other substances, right? Like a lot of this research is dependent upon self-report. But even when correcting for that as much as possible, meaning among families who have reported only cannabis use, not cannabis and alcohol or cannabis and another substance. Lower birth weight, small for gestational age, increased NICU admission, higher rate of perinatal mortality, stillbirth, right? And then as newborns, babies who have had exposure, right, demonstrate altered patterns of arousal and self-regulation, right? Regulating their autonomic system. Just saw something come up in chat. Let me just see. Yes, perinatal mortality means death, stillbirth. All right. And then, well beyond the newborn period, there are some studies that have found increased rates of neurocognitive and behavioral dysfunction, attentional deficits over time. And the largest study, and of course more studies are needed, but the largest study found longer term effects in children's verbal reasoning, language comprehension, executive functioning, right? As they became older and they were old enough to actually measure executive functioning. What do we mean by that? Executive functioning means impulse control, planning, organizing, decision making, right? And people who are already teenagers or adults who themselves had been exposed to cannabis during when they were gestating, when they were fetuses, show an increased prevalence of developing a substance use disorder or another mental health challenge. And again, the data it's difficult to have pure studies, right? Because if you have a parent who was seeking cannabis use in some ways to self-medicate around anxiety, it's possible, right, that that child would have gone on to develop a mental health concern around anxiety, whether or not they were exposed to cannabis. However, just looking at the cannabis exposure, yes, Monica, the whole idea is to try to help people stop as soon as possible during the prenatal period. And Ruth is asking, are these effects seen for those that used cannabis during pregnancy or also that used to smoke but stopped when planning a pregnancy and became pregnant? These are results for exposure during pregnancy,
Dr.
right?
Singer, you had
Yes, please.
you had two questions come in the Q&A box. The first one is asking, what is considered 10% maternal concentration to your second point on your slide?
Sure. So all that that means is that if there's a pregnant person, if there's a pregnant person who is using cannabis, that I'm sorry, excuse me, just for sorry about that. All it means is that the concentration of exposure in the baby's brain, right, is at 10% of what the mother or the birthing parent's level of THC is in their metabolites. All right. So in other words, it's not one for one. Like the baby is not getting the same exposure that the parent's brain is. It's at 10%, but this is a teeny tiny brain, right? Where we don't want any exposure, right?
And then
So
there's
yes,
one more.
please.
The second question asks, is there a difference between the types of exposure to the marijuana mother ingested, smoked, etc., secondary exposure through smoke?
Um, yes. So let's just, it stands to reason, right? That there's going to be more of a negative effect if the parent is directly ingesting or smoking the cannabis, right? Than if the parent's exposure or the pregnant person's exposure is through secondhand smoke. But the secondhand smoke still is metabolized by the pregnant person, and that metabolite is still passing through the placenta, right? So our goal is to also avoid, if you see the last point, also avoid secondhand smoke exposure to the pregnant or lactating individual, and then, of course, to the child as well, postnatally. All right. So let's think about postnatally. The THC, again, it's fat soluble. It passes through mother's milk. The data is difficult, right? Because often a parent who was using during pregnancy is then also using during lactation. But the uh, the concern is about any exposure, right? Whether that's the prenatal exposure or the postnatal exposure through lactation. So as recently as this past October, October 2025, and I put this citation, in the resources at the end, the American College of Obstetrics and Gynecology, their official stance is to advise cessation of all cannabis products while pregnant and while lactating. Okay, so now I'm going to say something that's going to feel a little confusing. All right. However, ACOG does not advise against breastfeeding, even if the lactating parent says that they are using cannabis. So some of you might be saying, what? I thought this webinar was going to help us tease this apart. Okay, so let's just work with this for a second. The advice is that there's no medical indication for the use of cannabis. It's not medically indicated for the treatment of nausea, for the treatment of emesis. In fact, it increases risks of hyperemesis. There's no indication that it's beneficial to the pregnant or lactating parent in terms of assisting with the pregnancy or the lactation. It's counterindicated, right, to have marijuana use, cannabis use during pregnancy or lactation. However, the ACOG, their official statement says, but don't advise the parent to stop breastfeeding if they are using cannabis, because there are so many other health benefits to the breast milk that the hope is that some of those benefits might outweigh the risks. But of course, that very much depends upon the um, the potency and the dosage of someone's use. And all of these studies are dependent upon people's self-report, right? All right. So let's think about this. All right. Some of the very same neural pathways in our brains as humans, some of the very same neural pathways that drive our parenting and attachment behaviors. Those are the same neural pathways that are negatively impacted or dysregulated by substance use disorder. Okay, now we're not saying that everybody who uses cannabis has a cannabis use disorder. A cannabis use disorder would convey that there's such regular use and dependency that someone has difficulty functioning without the cannabis use, despite any of the negative effects that it has also upon their health and relationships and day-to-day functioning. All right. But what we do know is that cannabis use that would rise to the level of a substance use disorder is also negatively impacting the parent's capacity for parenting and attachment. Even though what we also hear, right, from parents, as you all said in the chat before, who use cannabis, that they might report that it helps them feel self-regulated. And if we're advising that they reduce their use or cease their use, they might have a response, a cannabis withdrawal response, where there is increased anxiety, at least initially. So it's very tricky because we want to advise cessation, or at the very least reduction, and then be there to support the family as they experience some of the aftermath of that, even though ultimately that's going to be better for their parenting and for the baby. Let me just check the chat. Is there a difference between a mother being under the influence and breastfeeding versus using but not breastfeeding while under the influence? For example, feeding hours later after the effects have passed. Well, thank you for the question, Ruth. The problem is, right, that the THC has already been metabolized and passed through the placenta, right? There, oh, I'm sorry, you're talking about breastfeeding. So a difference between the mother being under the influence and breastfeeding versus using but not breastfeeding while under the influence. Again, ACOG would take the stance, there is no difference, right? Because if you're using, then it's getting into your metabolism. And if it's in your metabolism, whether or not the individual is still feeling the psychoactive effects, it has already um, been fat soluble and passed into the mammary glands. And then we also see in the chat someone who was reiterating this confusing but important distinction that yes, advised to cease cannabis use during lactation, but if the parent is breastfeeding, don't advise them to stop because the benefits might outweigh the risks. And there's a question in the Q&A box. Okay, let's see if I can see the Q&A box. Yes. Can it be advised that if they're going to use cannabis, to wait a certain amount of time after or before breastfeeding, similar to alcohol consumption? Right. So there's the same question that just came up in the chat, right? Um, and I would not choose personally to be in a position of implying to a parent, oh, well, then that would be okay, because any use is actually going to get into the breast milk. All right. So, given all of this, let's take stock and engage in some reflective practice. Okay. Um, let's allow awareness of our own emotions, our own reactions, even our own potential biases. Okay. So, as we engage with a family and it becomes known, either through the referral or the parent shares with us, that there was known cannabis use during pregnancy or while lactating, breastfeeding, or both. And I'm going to ask you to just take a moment to reflect upon your own emotions, your own reactions, your own judgments. All right. And like before, we're going to engage in a Mentimeter. All right. So I'm going to ask you to either engage through the QR code or through the link in the chat. As you think about all of the data that we've been considering, what are our emotions that come up when we discover, when we learn, when we know that there has been cannabis use, that there is ongoing cannabis use? I'm going to leave the QR code up for another couple of seconds, and then I'll pull up our word cloud. All right. All right. So take a look. We're worried, we're concerned, we're confused, we're upset, disappointed. We feel empathy for the baby, right? If we're building a relationship with the parent, we might have ambivalence. We want to feel compassionate and empathic towards the parent. We want to be supportive, but we also feel protective about the child, right? Scared for the child, angry, all the way through to non-judgmental, right? And it's really important if we're going to get to a non-judgmental place, right? It's important for us to be aware of what our emotions are first. Because sometimes if we're really busy warding off of our uncomfortable emotions, like, oh no, I'm not going to judge, um, we actually might find ourselves doing or saying something with a little bit less intention. Letting ourselves be aware. I feel conflicted. I feel worried about the child. And then there's this question, is it reportable? All right. And we can have let's we'll have a little side conversation about reporting, right? Because, because in this country, not just California, across the country, there are inequities in who it is that gets reported. There are inequities and imbalances in who it is prenatally in the hospital who gets referred for drug testing, right? And the ACOG's position at this point is that there should not be um, uh, blood testing as a matter of course in order to identify cannabis exposure, because largely of the inequities that have happened in the disproportionate rates of families who've been referred for child protection concerns who are Black and brown families, far more likely, right, to generate a report, even though cannabis use is across all demographics. All right. So the first step in our family engagement that we have been exploring here has been reflective practice, allowing ourselves to be aware of our emotions. That's step one. And then once we really engage in that reflective practice with the information that we have, right? Because boy, if it was so easy to just say to people, there are too many risks to cannabis use during pregnancy. So, the general advice is to stop. If it was that easy, right, then uh, then we probably wouldn't even be having this webinar, right? So we want to start with reflective practice, be aware of our own emotions, be aware of our own judgments and biases, because that's going to potentially play itself out in the relationships that we're trying to build with families. And then we can turn towards relationship-based care and really embrace the idea of parenting and attachment and the emotions that parents have about parenting, about their child, as being a source of motivation. Because all of the things that might drive someone towards cannabis use, let's say like reduction of anxiety or stress, can be helped by engaging the parent in active involvement with caregiving for their baby, because that active serve and return engagement with the child has the potential to help reset the reward system in the parental brain. And parents ceasing or reducing their substance use need extra support navigating the demands of that process, right? And the demands of parenting. What we really want to do is turn to the power of the relationship, turn to the power of that sense of success in parenting as a primary goal for parents, to help bust stigma, to help kind of build those relationships despite the stigma that families might feel as a barrier to self-reporting, to seeking help, to seeking support. So our next step, first step, reflective practice, be aware of our emotions, our reactions, our judgments. Then turns towards relationship-based care. What's our next key strategy? Is despite our worry, despite our concern, despite our sadness that we all, said in the word cloud, what are some ways that you already treat parents like you have something to learn from them? Meaning, our next step is to intentionally adopt an attitude, a strengths-based attitude, despite our uncomfortable feelings. Because our temptation, right, when we're feeling judgmental, we're feeling worried, is to act in ways that are protective towards the child. And that might actually not build a relationship with the family. So I'm really asking you, what are some ways that you already treat parents like you have something to learn from them? And I don't mean when it's easy, when like, oh, what you see in front of you is just such a source of celebration for us that we're just so happy for that baby and for that dyad and how they're doing together. I mean, when we're feeling uncomfortable with something the parent is doing, let's say cannabis use, how do we purposely, intentionally treat them like we believe that they want to do well and that we have something to learn from them? So in the um, in the chat I'm seeing, I tell them I'm proud of them just for sharing. Myra, meet them where they are. Yeah, so we're going to tease that apart. What does it mean to meet them where they are, right? What are the ingredients in that? I'm going to ask questions, be empathetic to their why. Always treat them like they know themselves best because they do, and they know their own situation best. Appreciate their vulnerability in opening up to me, right? Opening up to us, right? That is a strength when someone reveals their vulnerability. Um, I'm really concerned about the reporting because I'm so lost on this one. Yeah, we'll come back to the question about reporting, right? There, I think what we're talking about is that it's not an automatic report, right? It's not an automatic report. If there's multiple pieces of data over time, right, that there's excessive exposure, then it's different. Yvette, strengths-based approach, actively listening. Reassure them that we're there to listen, to provide support. Listening, praising the small accomplishments. Yes. So all of these key ingredients in your home visiting strategies that you use in service of parenting in the first place are, um, are key ingredients in partnering up with families to help to ignite some motivation for change around cannabis use. Open communication, listening to understand, not to respond. I saw something else. Aurora, requesting permission to share a story. Yeah, right? Not getting top down with our psychoeducational information, but instead of coming in from the bottom up. May I share a story with you about another family I know, another child? Ask permission to inquire about the reasons for using. Yes. So you're bringing us right to this next section, right? So what are our engagement strategies? Universal screening. And I'm not talking about blood testing. I'm talking about using an evidence-based screener tool like the TAPS. And I have the citation in the last slide. TAPS is the Tobacco, Alcohol, and Prescription Medication and Other Substance Use screener, right? Making it a regular part of our interactions with families, right? And that's in one way how we avoid bias, right? If we're doing universal screening, something we do with everybody, right? And then, as you saw in the chat, what are some of the ways that we can get to the motivational interviewing? How do we explore, discover, wonder with families about their personal motivations, their values, their priorities, right? Some people will report to us that cannabis use helps them avoid more dangerous drugs. Okay, well, that's a different kind of referral, right? For more intensive recovery support. Some people might report that the cannabis use helps to alleviate mental health concerns, right? That's another potential referral, right? Right? So we're here to discover What's motivating them? What is it that brings them relief? As Myrna said in the chat, respectfully ask permission to inquire about the reasons for using. We want to understand. And then also recognize current and anticipated barriers, right? Social determinants of health and other stressors. Okay. What are the other stressors that the family might be contending with? Can we help with some of those? Is there food insecurity, housing insecurity, et cetera, et cetera? And to really offer up supports if it feels like, oh, this is outside my realm of what, okay, where do we look for the additional referrals and supports if we feel like, oh, this is someone who's at high risk or who's showing that they're experiencing cannabis withdrawal syndrome, which can spike anxiety, right? And referrals for more support for cannabis use disorder. Um, Anna, are you able to hear me? Because someone is saying that they lost audio.
Yes, we can hear you and see you.
Okay, terrific. All right. So, again, as Myrna so beautifully and wisely said in the chat, we want to identify, yes, the risks of use and the benefits of cessation, right? We're going to bring our knowledge and enlightenment to the family, but how we do it can make all the difference, right? How we do it by assuming that this parent wants to do well by their child. And we always want to be identifying protective factors. Who's in that family support system? Their partner, their family members, right? Who can come alongside the family in their efforts, right? If they have a partner who's also using, we want to involve that partner in these conversations. Okay, in the chat. Oh, sorry. All right. All right. So, step 3, motivational interviewing. What does the parent want for the baby? Right? How might we engage a parent in wondering about their priorities and values? What do they want for their baby? And what do they want for themselves? Right? And this is where all of your work in the early childhood space is such a powerful ingredient in supporting families in this effort to cease or reduce cannabis use, because you're there in service of their relationship with their child. So, step 3, wondering with the parent about what they want for their child and for themselves. How do you already do it? How do you already engage with families to be thinking about the hopes and wishes and dreams that they have for their child? I'm going to look in the chat for a few examples. And then we'll contrast that with a purely top-down psychoeducational approach, which would be like telling the parent about all the risks, etc. How do we enter in from a relationship-based place to be wondering? So anyone in the chat, how do you already engage a parent in wondering about what their priorities are, what their values are? We heard a lot before, asking permission. Can I share a story? Do you mind if I ask you why? What is it that you're hoping for? But what about this idea of wondering with the parent about what they want for their child? Open, do they have questions? Oh, HFA, family values activity. Yes. So Healthy Families America, right? So some of our tried and true strategies, right? Asking about families of origin, asking about practices that they learned, that they saw in their households. Do you want to do it that way? Do you want to do differently? Asking about their values in the family goal plan, right? Their family story. What do they want for their child? What do they want for their child tomorrow? What do they want for their child 5 years from now, 10 years from now, when their child is an adult? So that step 3 really is important, right? Yes. Ask about their upbringings. Beautiful. Thank you, Deborah. Yeah. So we're really engaged in that parallel process. So I've borrowed here from the WAME Handbook, the World Association for Infant Mental Health Handbook of Infant Mental Health. I have the citation in the last slide. Here's some of our key elements for infant mental health. The physical and emotional health of the pregnancy and of the birthing parent, right? The physical and emotional health of that developing fetus. And then support for healthy attachment in a safe and nurturing system, right? And then we're coming into the system with our capacity for compassion and self-regulation in support of being able to mutually regulate the parent. Our relationship with the family is going to help them practice their self-regulation skills, right? Self-regulation that maybe somebody was relying upon the cannabis use to achieve. And we're coming along to offer up predictable, contingent nurturance, ourselves towards the parent towards the child. How do we do that? Well, if we operate from this last step, nothing is more motivating than the hopes and dreams of a new baby. How might we engage a parent through their interactions with their child? And here's where I'm invoking a foundational strategy from the Brazelton Touchpoints approach, which is using the baby's behavior as our language. How do we just come alongside and bear witness? Observe what we see, say what we see, just narrate what we see, and pause and invite the parent to share with us, right? It's such a shortcut into the inner emotional life of the parent. And that's what we're doing here is we are scaffolding the parent's motivation, right? Their motivation, let's say, for their baby, their motivation to cease or reduce the cannabis use. And we're doing it through the relationship with the child as a protective factor. So I'm going to give you an example for your consideration. All right.
Dr.
And
Singer,
yes.
sorry, before you do that, you did have one question come in the chat. Someone asked, would you have any different strategies if you're working with a young parent who is in the child welfare system as a youth?
Oh, I see it in the Q&A. Would you have any different strategies if you're working with a young parent who's in the child welfare system as a youth? Honestly, I would say it's even more important to treat that young parent as if we have something to learn from them, because they probably are finding at every turn attitudes and reactions towards them that send a message that they don't know what they're doing. So I wouldn't say that it's a different strategy. I would say it's even more of the same. Recognize our protective urges. We might have feelings, right, about a 15-year-old, a 16-year-old who's using cannabis and pregnant. Be aware of our emotions and then intentionally adopt a strengths-based attitude. What does this young parent have to teach me? What are their priorities? What are their values? What do they want for themselves? What do they want for their child? And then coming alongside this strengths-based strategy of using the child's behavior as language. So I'm going to ask you, whoever asked that question, in this next little exercise, imagine yourself being that young parent in the child welfare system. Okay? I'm going to ask everybody, imagine yourself being the parent in this next scenario. And here's your baby. And let's just say your baby is in the NICU. Your baby was born small for gestational age, low birth weight. There is an admission to the NICU, and you've been using cannabis. All right? And I'm going to ask you to imagine just being that parent as, let's say, I come up alongside of you and I say to you, you know, her eyes are closed and it might feel like she doesn't know you're here, but I promise you she does. And it's so, so important that you're here. I'm glad you're here. Your baby is benefiting from you being here. And I know it can be really stressful to be here. So please, we're here for the babies, but we're here for you. If there's anything that you need from us, we're going to check in with you also. All right. So let's just pause for a second. And I'm just going to ask you, and you can just say in the chat, yes or no. Did I sound kind and compassionate? Mm-hmm. Did I sound like, oh, it's really important? I think it's important for babies and parents to be together no matter what the circumstances. Mm-hmm. And that I'm thinking about the whole family, not just the child. Mm-hmm. Okay. I'm going to suggest to you that that's not enough and that we can do more. So now I'm going to ask you to still stay being the parent. And now I'm going to use this relationship-based strategy of saying what we see. So instead of what I've just said to you, you're the parent, and I come alongside you and I say, huh, look at her with one arm stretched out and one elbow bent like that. Now, you as the parent might not know it's a tonic neck reflex. Doesn't matter. Look at that. Nice, healthy newborn reflex. Wonder what she's going to do next. What do you think she's going to do next? Even if you as the parent don't know, I don't know. Well, can we watch together? Let's watch together to see what she does next. Because her eyes are closed. It looks like she's sleeping. But look, her legs are up, her toes are splayed. She's not really asleep, is she? So let's see what she does. Let's just watch together. Oh, look at her. She pulled her arms in. And when she pulled her arms in, she got her hand to her mouth. And when she pulled her arms in, that made her sort of tilt over to the side. Look at that. Her back is rounded. She's in the position she probably was when she was inside you. And look at that. Now that she's on her side like that with her arm on the mattress pad, she can get her fingers to her mouth. And with her little fingers in her mouth, what happened? Somebody say it in the chat. Use the baby's behavior as your language. What did she do? Anyone in the chat? What did you say? I'm circling it. She opened her eyes. Look at that. When she got her hand to her mouth, she opened her eyes. Would it be okay if we picked her up? Now that her eyes are open, let's pick her up. Oh, she's looking off to the side. It's okay. Keep talking to her. Keep talking to her. Oh, there she is, looking right at you. Anyone in the chat, what's just happened to you as the parent? What's just happened inside of you emotionally as the parent? Connected. Connected. I fell in love. Yes. I feel empathy for my child. I feel connected. I feel supported. Broken down inside with love. Relieved. My baby is not all damaged. In love. Yes. And that love, that connection we're going to seize that as the primary connection, the primary motivation for reducing or ceasing cannabis use. And I have been given a new start. Yes, Elizabeth. And can I just tell you, in terms of healing for these brains, the birthing parent's brain and the baby's brain, in that moment of mutual gaze, right? What's called serve and return, the parent's brain and the baby's brain are both going to produce their own endorphins, their own naturally occurring endorphins, right? So this face-to-face care is crucial for engaging the baby and the parent in any kind of motivation for cessation or reduction of cannabis use. So what we've been exploring is something that all of you are so very good at. You've mentioned HFA, home visitors, you know that lactation specialist, like you know how important relationship is. And the most important, the key to substance reduction or cessation is motivation. And parents might not seek reduction for their own sake, but they might for their babies. And nothing is more motivating than the new baby. And understanding the baby's behavior and being there in service of attachment leverages the new parent's biological hardwired motivation. So, to summarize today, there are no medical indications for cannabis use during pregnancy or lactation. There aren't, right? All of us as practitioners, no matter what our discipline of practice, should be aware of the possibility of cannabis use during gestation and lactation through universal screening, and counsel clients to reduce or eliminate cannabis use, right? In relationship-based, respectful, family-centered ways. Step 1, be aware of our own emotional reactions, right? Step 2, be aware of whatever judgments and uncomfortable feelings we're having and intentionally choose a strengths-based attitude towards the parent. They have something critical to teach me about themselves and about their child. I'm here to wonder and be curious. Ask for permission, right? Next step. Find the portal into motivation through the child's behavior, through the baby's behavior. What do we notice? How do we narrate what we see? Just say what we see as a way to focus on their relationship and get to that place of really facilitating the emotional bonding and attachment, because that's going to be a primary motivator. Even if we wish and want all lactating persons to not be using cannabis, if they are using cannabis, we're not recommending against breastfeeding. That is, we're advising against cannabis use. We're not advising against breastfeeding. And what are some of the evidence-based strategies that we've been highlighting? Universal screening, universal, not biased screening that amplifies health inequities, right? Motivational interviewing, really coming alongside the family to discover, well, what is it that was leading to the use in the first place, right? Using the child's behavior as our portal into wondering and exploration, and then helping the family find their avenues towards coping skills. If it was anxiety that the cannabis use was sought for, where are other avenues for stress management and addressing anxiety? Quality of life improvements, right? What are the social determinants of health that the family is contending with? That if we can alleviate some of those stressors. And then, of course, depending on your role with the family, referrals for more intensive support for cannabis use disorder, cannabis withdrawal syndrome, mental health concerns. So I'm going to land on our resources. And I'm actually, how about this? We, I will even just put them right here in the chat for you. Oh, it won't let me do it. Never mind. So you will have this handout with these resources with their hyperlinks where you can go directly to the resource and learn some more. One of the resources is a brand new book that was just published called Promoting Healthy Outcomes During Pregnancy and Beyond, that was developed and written here at the Brazelton Touchpoint Center with and in collaboration with parents as teachers. It's a beautiful resource that can help us think about not just cannabis use, but many, many, many other aspects of supporting uh, uh, pregnant persons, developing fetuses, perinatal period, postnatal, and beyond. So as we say goodbye today, I'm just going to invite you to share in the chat what's one idea, what's one strategy that you're taking away with you today that you can apply in your work. All right. And of course, thank you so very much, not just for joining me and supporting each other today with all of your great ideas, but for the work that you do every single day with children and families. But please do share. What's an idea or strategy that you're taking away with you today that you can apply right away? And we'll take a look in the chat to see what they are. Ask questions first. Lots of thank yous. Listening. Yes. Yeah. Taking the parent's perspective. Observe and be mindful of the moment that we have at hand. Yes. Narrating the child's behavior builds connection. Lead through the child's behavior. Oh, yes. Listen, don't judge. What is the story? Work holistically. Beautiful. So thank you all. So checking out my biases. Yes, the data is really clear on this, on who it is that gets reported for protective filings. And it's disproportionately Black and brown families. And it doesn't mean that other families are not using. Encouraging engagement and involvement with the children despite the issues and concerns. Yes, it's the number one protective factor for that parent and for that child. Making sure to understand where the parent's knowledge starts, leaving my belief system at the door. Yes, compassion and respect. Um, Beautiful. Empathy and support. Do not advise against breastfeeding. Yeah, yeah. And looking for um, your colleagues. How do you, depending on your role, right? If you have a concern, can you build a relationship with the family's OBGYN, the family's midwife, primary care, right? Build that supportive system around the family. So thank you all very much. Thank you again to LA Best Babies for having me. And you never know, maybe I'll get a chance to be with you again in the future. And if you'd like to learn more about the work that we do here at the Brazelton Touchpoint Center, the website is here on the last slide. And I hope you have a great rest of your day.
Thank you so much, Dr. Singer. This was a very informative presentation, and I know you got lots of love in the chat, but we really
I see.
appreciate you
Thank
taking the
you.
time to help train us. We all learned so much from you and your wisdom and knowledge. So again, thank you so much. I will go ahead and share my screen really quickly, just because in true consortium fashion, we always want to hear from you. And as I mentioned previously, we will conclude with a quick evaluation. You should be able to see this as you exit the Zoom. A pop-up should follow after you exit this Zoom webinar, but just in case, I am putting it up here so you can scan the QR code really quickly or use the link that my colleague is going to paste in the chat. But again, thank you all so much for joining, and a final thank you to Dr. Singer. Thank you so, so much.
Thank you so much. And thank you to Lynette and Anna for all the back end help. Can't do it without you. All right. Take care, everybody.
Take care, Dr. Singer.